longer as time goes on. What we see is that this can happen in migraine. It can sometimes be a bit off-putting in many ways. If patients report, say, lacrimation, conjunctival injection, or nasal congestion with their attacks of migraine, it can be a little bit distracting. However, they tend to be less prominent, less consistent, and more likely to be bilateral. And that's a useful hat to hang one's coat on, so to speak. So where does this all come from? Some time ago, we did some experiments to show that if you could set up a model, an experimental animal, and show that you could activate flow mechanisms, cranial flow mechanisms in a spinal cord section animal, so it takes out the rest of the physiology, that was mediated through the sphenopalatine and otic ganglion. I've labeled it pterygopalatine. You can argue what you might want to call it an experimental animal, but it's sphenopalatine in humans. And you could show that there was central nervous system mechanisms that could activate a cranial autonomic pathway via these cranial autonomic ganglia. So you can see on the right side, it's old data, but it is what it is, that you could do through sectioning of the nerve and stimulation of the ganglia, you directly show the sphenopalatine was responsible for the broadest part of this activation. Now, you could also show, as Simon Ackerman's done, that there's an interaction, and the reason I'm building this up is probably you realise for the basis of what we talk about in therapy later on, you can show that there's an interaction between neurons that you can activate through stimulating the superior salivatory nucleus, that reflex structure, that can be modulated here, as Simon Ackerman's showing it in experimental animal, by stimulating the vagus nerve in the neck. So taking a vagus nerve stimulator, putting the alligator clips on it, directly stimulating the nerve. You see in the bottom there, an inhibition of spontaneous firing, an inhibition of the superior salivatory nucleus reflex activation. So vagal input to this cranial autonomic pathway. A marker in humans that takes that I've shown you, the sphenopalatine activation, various experimental work, into humans is a work here that I did with Lars Edvinsson some years ago, showing that in patients with cluster headache, they would release CGRP and vasoactive intestinal polypeptide. You know, it's a marker of sphenopalatine activation, not neuropeptide Y or substance P. And the neuropeptide Y it's a marker of sympathetic activation. It's also quite useful as in terms of a control for dilution effects of the collection. Fanciolacci showed in nitroglycerin triggered cluster attacks against CGRP release, and that was resolved by sumatriptan, and that's entirely in line with our experience that you can trigger these attacks when in about. We also showed in the brain paper that oxygen would reduce the CGRP levels, as would sumatriptan, just as Fanciolacci did, but non-specific opioids didn't. They really don't stop the attack. This is an injectable opioid that was used in Australia at the time. So you can dull the pain, but you don't actually do something for the attack with opioids. And that's a message I think that rings true in clinical practice. So again, when you think about these neurons that might be responsible, Simon, here we developed a model of the cranial autonomic outflow to study these mechanisms. You can see that if you're stimulating dural structures, just alone dural structures, the classical thing we would do if we wanted to examine a migraine model, so stimulate the dura and record in trigeminal-cervical complex, the top right panel, and you can see where the neurons are in the little stained panel. In the bottom, you see that naproxen will block that sagittal sinus activated trigeminal-cervical neurons, but oxygen, bottom on the right, will not. And hexamethonium bromide doesn't have any effect. Why do we do that? Hexamethonium bromide is a nicotinic ganglion block, autonomic ganglion blocker, so it blocks the sphenopalatine transmission pharmacologically. So what it suggests here, not surprising perhaps, is that naproxen has no effect on these neurons. Now, in contrast, you can identify in the trigeminocervical complex, what we call long latency neurons that would be inhibited by oxygen and would be inhibited if you block that sphenopalatine transmission. So there are neurons that are trigeminal activated, have an interaction with the superior salivatory nucleus outflow pathway that you can inhibit with oxygen. We think that's part of the mechanism of the effect of oxygen. Here in some detail, again, looking at the other side of this and not recording from the neurons here, but talking about, I want to emphasize talking about the cranial autonomic outflow pathway component of this, recording lacrimal gland flow. You can see tightly linked activation of flow with stimulation, and then you can see on the bottom in the middle that you can block that with oxygen. So you can reduce the cranial autonomic outflow and trigeminal activation with oxygen. There is a nitrogic component to this. It's not been exploited clinically, but it's sitting there waiting to be. This is cranial autonomic outflow. And what I'm showing in the right panel is a nitrogenine methyl ester, which is a non-specific nitric oxide synthase inhibitor, will block that pathway. Again, not entirely surprising because the sphenopalatine ganglion has nitric oxide synthase, offering a way to think about other therapeutic options. Now let's think about the brain. I've talked a little bit now about the trigeminal autonomic reflex, but cluster headache at its core, and the TACs, I think, are what they are because of the way, because of these brain structures that are driving this final common pathway. And this is work that Anna May did when he was with us, showing activation using PET in a region of the brain that's just at the back of the posterior hypothalamus. People spend a lot of time arguing about what to call this, which is a bit silly because in humans, this area, you could give it a broad name, it doesn't really matter, but that's where it is, just in the back of the hypothalamus, which on MR is just an artificial line in the sand, not in the sand, in the brain. There's a particular group of neurons there. When we've understood what they are, that's what we'll call them. And the rest of it's gravy at some level. This area is activated. I think that's particularly true, and it was particularly useful to see this stimulation work that was done, the brain stimulation, and what it does is, I think, not terribly, for most patients, not a place to go therapeutically, but from a physiological understanding, quite rewarding to know that stimulation of this region of the brain that Sarno labeled as the posterior hypothalamic region in patients who are awake. This is obviously neurosurgeons, very often people keep people awake when they do destructive surgery. They learn very quickly if you stimulate this area of the brain in humans, the person becomes restless, agitated, and wants to move about. I don't think it's any surprise that a region of the brain that turns on imaging that can be useful if you manipulate it with stimulation also is an area of the brain that, when you stimulate it, results in a phenotype, if you want, phenotypic manifestation that's very typical of what you see in the disorder. This region of the brain is not the suprachiasmatic nucleus, but it's not far from it. And thinking about those connections is important in terms of understanding both the circadian and the circannual pattern of cluster headache. And it's one of the really fascinating things. This is the timings. This is from Barlow-Acey and Rigmore Jensen. It's work nicely documenting, particularly the circannual distribution is fascinating. I mean, we could talk about suprachiasmatic nucleus in terms of circadian changes, but the circannual variation is extraordinary when you think about it. All of us sitting on the Earth, all species basically, are subject to the effect of night and day, and also subject to the effect of the length of night or the length of day. And I think as we understand this, it's a fundamental piece of physiology. We'll understand better how cluster headache cycles in a circannual fashion. something we don't understand terribly well, but is consistent with this lateralization manifestation of cluster headache, is lateralization of something like photophobia and phonophobia. So in patients who've got a personal family history of migraine, this tends to be the group, they'll very often report, maybe 2/3 of them will report some form of photophobia with attacks. And it's quite stunning how clear they are that it's homolateral with their pain. This is a question I don't pretend to understand. It's useful clinically. You know, as we understand the lateralization aspects of the physiology of cluster headache, I think we'll come to try and understand this. For me, like, as I said, one of the really great prizes would be to understand this distinction between episodic and chronic cluster headache in terms of the turning off. This is nice work, Volleson from Masudashina, the Danish Headache Centre, looking at patients triggering with CGRP. So what they saw was 8 out of 9 patients triggering with CGRP an attack when they're in bout, and none when they're out of a bout, and none triggering with placebo when they're out of a bout. Because when they're out of a bout, they're out of a bout. It's extraordinary. In contrast, the chronic cluster patients, about half of them triggering with CGRP, and more likely to trigger if they were the group that had had more attacks in the previous month. So there's something about how active the disorder is. I think this is quite important in terms of understanding also clinical trials and clinical trial outcomes. Chronic cluster headache patients still cycle in this circannual fashion because obviously they can't get away from the sun, I suspect, if you think of it that way. This is some work that just coming out in CEPHALALGIA that Diana Way did, looking at, again, triggering. We use nitroglycerin triggering to look at phenotype, single-blinded nitroglycerin triggering in episodic and chronic cluster headache. We saw, as you can see, the chronic cluster headache patients tend to take longer to trigger. And in contrast to episodic cluster headache patients, it's a survival on data on the left panel of no headache, so to speak. And then we're looking at the symptomatology. These are violin plots. It's a nice way, non-parametric way to show the distribution of the pain, the cranial autonomic features, not just in box and whisker, which you lose a lot of detail, but you can see that the distribution of the way the pain comes on and the cranial autonomic features and these non-headache features is quite distinct when you're triggering these attacks. I think this kind of analysis will help us, again, understand the detail of the difference between the conditions. So when I talk to patients with cluster, I sort of talk about these two things. The trigeminal autonomic reflex explains a lot about the pain, lateralization of pain, the cranial autonomic features, and the brain structures that are involved. Particularly, I think this region I'll call in the rear, the posterior region of just behind the hypothalamus, I think is potentially crucial in understanding bigger picture things about how the disorder entrains lateralization, for example, or entrains the circannual and circadian rhythm. This is the trigeminal autonomic cephalalgia family. They all use this pathway. There's variation in the way the central nervous system activates on functional imaging, and that's just at the absolute core of understanding the distinctions between these attacks. I think it's useful to frame up what one tells patients with cluster headache in the context of understanding as much of the biology as we can. And the more we understand, I think the easier it is to practice, and in many ways, the more satisfying it is when one sees a patient. I'm going to stop there, conscious as I am that babbling too long on a webinar is death. Pause, see if there's anything that we need to talk about before my colleagues move on. I'll hand it back to Faiz.
Thanks, Peter. Thanks very much. Very comprehensive. I mean, if somebody wants to hear the most important bits of a topic in 15 to 20 minutes, I think Peter is probably the best person for that. So yeah, we'll have 2 more speakers, and then we'll come back with the question answers at the end. So thanks, Peter. So our next speaker is Alina Buture. Alina has recently finished her PhD on the early diagnosis or misdiagnosis of cluster headache. I think there has been quite a few cases reported where people with cluster headache being diagnosed as trigeminal neuralgia, sinus-related pain, tooth-related pain, and some people even have had surgery done for all those to find out later that they had cluster headache. And cluster headache is the most painful condition to affect humankind. And therefore, it is important that we get the diagnosis early and treat it appropriately. A delay in the diagnosis, I think 25 years ago, there used to be about 9 years, then it's 3 years. And I think Alina is going to tell us whether the time to present and time to diagnosis have changed at all in the last few years. So Alina is currently working in Dublin. We had the pleasure of having her in Hull until about a couple of years ago. So Alina would tell us about Dublin. We're out of Brexit now, so you're alien for us now. So let's hear Alina about her PhD.
Thank you, Faz, for the invitation, and thank you, Prof, for a very interesting presentation. My presentation is focused on the delays in the diagnosis and misdiagnosis of cluster headache and how we might be able to improve the diagnosis. The presentation is really for people that don't have that much experience with cluster headache. I think the content will be fairly familiar to a headache audience. So I'm going to start with the case that highlights the challenges in the diagnostic journey of cluster headache, something that we often see in clinic. So this is a 35-year-old male with no background history and no medications at home. He presents with a 2-week history of pain in the left orbitomaxillary region. He goes to the dentist and he gets a tooth removed. There is no improvement, and he goes back to the dentist and he gets another tooth removed. The pain settles after a week, and the next year, patient experienced similar pain for about a week, goes back to the dentist. He is given antibiotics and painkillers. There is no improvement. He goes back to the same dentist and he gets another tooth removed. The pain settles and the patient is pleased. However, the following year, same thing happens again. The dentist is away and he goes to his GP and he's given antibiotics and analgesia. There is no improvement and he's referred to the headache clinic. In the headache clinic, he describes 3 episodes, each lasting 3-4 weeks, with onset usually in September, with throbbing and excruciating pain in the left V1 and part of the V2 distribution, with autonomic features of lacrimation and rhinorrhea. And the attacks start usually at 4 a.m. In the morning every day. So based on the history obtained in the headache clinic, he's diagnosed with a left-sided episodic cluster headache. And I think this case really highlights the challenges that some patients face. They could see several clinicians, dentists, ENT specialists. It could take a few years before they receive a correct diagnosis and they get a proper management. So cluster headache, as Prof. Goadsby mentioned, it's uncommon, but it's not a rare disease. About 1 in 1,000 people suffer with cluster headache, which is similar to the prevalence of other well-known neurological conditions such as MS. So the first worry when we see patients with cluster headache, let's say when they have their first attacks and they present to hospital, if they get admitted or if we see them in ED, I think the first worry is to rule out a secondary headache. And this is a systematic review from 2014 of symptomatic cases of cluster headache. 30 patients actually met the ICHD criteria for cluster headache, and some of them had vascular disease, especially dissections. Half of them had tumors, especially pituitary tumors. So if I see these patients for the first time, for example, if they get admitted to hospital, I usually get a CT and a CT angio, and then I make sure they get an MRI as well to rule out a tumor. Especially pituitary tumors could mimic cluster headache. And I'll show you an example of a 25-year-old with a diagnosis of cluster headache who tried multiple medications. And he got an MRI when he started to lose his vision. His prolactin level was really high, about 11,000, and he had a huge tumor. He was diagnosed with a prolactinoma. Fortunately, he had a good response to treatment, to cabergoline, and he's doing much better. So we've noticed from practice that there are delays in diagnosis and misdiagnoses, but let's see how severe the problem is. So this is a systematic review from 2018. 15 studies were included with more than 4,000 patients. The most common misdiagnosis was migraine and trigeminal neuralgia, ENT and eye disease. Delays could last from 5 years up to 30 and 40 years in some patients. And on average, patients saw about 4 clinicians. And some of them had unnecessary procedures like teeth extraction or sinus washout. And this is a list of misdiagnoses that the patients received in this review, from primary headaches to psychiatric disease to depression to allergies. And that's a kind of a long list of clinicians that they saw. They usually go to their GP, ENT specialist, dentist, ophthalmologist, but they even went to cardiologists and orthopedic surgeons. I'm not sure how that was helpful, but it kind of just tells you how desperate these patients are. So let's look at the clinical characteristics of cluster headache versus migraine and trigeminal neuralgia, because these are the most common misdiagnoses. So as I said, cluster headache affects about 1 in 1,000 people in the general population. And what I found curious is that although trigeminal neuralgia is less common, cluster headache gets misdiagnosed as trigeminal neuralgia. About 4 or 5 people in 100,000 suffer with trigeminal neuralgia. More men suffer with cluster headache and more women with migraine and trigeminal neuralgia. But according to all the reports, the gender ratio was higher, 5:6 to 1 or 8:9 to 1, which suggests that cluster headache is not a male dominant disorder as we once thought, probably because women get recognized more, I suspect. The pain is mainly in the V1 area in cluster headache, and in trigeminal neuralgia is a V2 and V3 pain, and very rarely V1. And as we know in migraine, any part of the cranium can be affected. The attacks can last up to 2-3 hours, as we know. But I think when people have cluster headache and migraine, the picture can be is not necessarily very clear. So what I sometimes do in clinical practice, I ask the patients to complete the 24-hour headache diary just for the purposes of diagnosis. Obviously, it's not something that they would want to do every day, will drive them crazy. But for the purposes of diagnosis, I find this useful sometimes. This is a patient with cluster headache, reported 3 attacks within 24 hours, maximum intensity 10 out of 10, duration between 2 and 3 hours. And in migraine, the pattern kind of fluctuates from mild to moderate to severe pain. So the pattern is different. And I think this diaries could be useful sometimes. Unlike other primary headaches, patients with cluster headache display a restlessness behavior. So it's not just a feeling of restlessness. They pace the floor, they rock their body, they hit their head, and it's something that we don't see in other primary headaches. And sometimes when I'm not really happy with the history that I'm getting from patients, I open YouTube and I show them a video of a patient with a cluster headache attack. And I'm just going to play this for a few seconds for maybe some of the audience that hasn't seen the attack. Well, we'll just stop it here. I think it's a video that is quite difficult to watch. Not all attacks are as dramatic as this one, but sometimes I find it useful to see what's the patient reaction. Some patients might say it's exactly what I'm experiencing. Others might say, no, definitely it's not something that I'm experiencing. However, I feel that sometimes it gives me more insight into what's happening during the attacks. There are no studies that have looked into how to use videos to help the cluster headache diagnosis, but it's just something that I use in clinical practice. I'm not sure if anyone else does that. Professor Goadsby has already mentioned the study from 2009 that looked at the cranial autonomic symptoms of patients with cluster headache and migraine. Most of the patients with cluster headache have autonomic symptoms, but they are severe, unilateral, and consistently present from one attack to the other, while in migraine, although half of them have cranial autonomic symptoms, they're not that severe, they're usually bilateral and inconsistently present, and we don't see that in trigeminal neuralgia. In terms of triggers, alcohol can trigger a cluster headache attack very quickly within minutes, and migraine can take a few hours. Also sleep, we know that cluster headache patients can have attack during sleep. Also, if they have a nap during the day, they can get an attack. We know that cluster headache is associated with the onset of the REM sleep when the oxygenergic system is downregulated to add sleep. And we know the usual migraine and trigeminal neuralgia triggers. So we know there is a problem that patients get misdiagnosed, but there are not many studies that looked into why this is happening. There are two main studies in the last 20 years from Vikelis and Rappaport and Van Vliet. So I combined the results from these two studies into factors with statistical significance and without, and they basically looked at the clinical characteristics of the attacks. So factors that delay the diagnosis is when patients were seen. So if they were seen before 2000, they were more likely to be misdiagnosed. If they had episodic cluster headache, which understandably, probably patients don't seek medical help if the attacks stop. If there is a side shift between bouts, which can happen in cluster headache, but it's rare, if there are migrainous symptoms or if there are nocturnal attacks. And the clinical features that don't delay the diagnosis, I've just listed a few of them here, ear location of pain or absence of autonomic cranial symptoms, interictal headache, restlessness. However, I feel that these findings are difficult to be translated into clinical practice. And I think it's not just about the clinical characteristics of the attacks. I think it's more than that. If people haven't heard about cluster headache, they are not going to think about cluster headache. We also identify some factors involved in delays in a qualitative study that we've done a few years ago. It was an impact and perception study with semi-structured interviews. We interviewed patients with cluster headache, GPs and neurologists. And among other things, we found some factors that delay the diagnosis, and we separated them into patients' factors and clinicians' factors. The reasons why patients don't seek medical help, one of the reasons is stigma of headache. Some patients said they are too embarrassed to tell anybody. Others had a tendency to normalize their symptoms. They thought it's nothing serious. Others thought they have a migraine or a dental disease or a head trauma. However, the list of clinicians' factors is much more longer, but I'll mention only a few that we identified. So clinicians think that if there is a mixed syndrome, cluster and migraine, patients tend to be misdiagnosed. Also, they said that primary headaches are not prioritized in general. Once a secondary headache has been ruled out, usually people don't bother to characterize the primary headache and to kind of manage it accordingly. There seems to be a problem with short consultation time, especially in primary care, and there seems to be a confusion between the terms cluster headache and cluster migraine. Also, patients suggested that cluster headache is not a good term for this disease, and Professor Goadsby was mentioning all the other kind of terms for this condition. And especially patients are not happy that the word headache is there, because headache is generally perceived as something that is benign and is not serious. And patients were very creative. They suggested different other terms, which I think they are good, like cluster agonies or killer headaches or completely blinding headaches. And it's something that I've heard in clinical practice as well. Patients kind of complain when you tell them, how are your headaches? It's not all negative. There's been a reduction in the delays over time in a few countries. In UK, there's a study from 2004 from Anish Vare and Professor Goadsby that showed reduction in delays from 22 years to 2.6 years between 1990 and 1999. Also in Greece, similar results from a study from 2016, reduction in delays from 20 years to 1 year, and a more recent study from the Danish Headache Center that showed diagnostic delays were significantly reduced for each decade of cluster headache onset from 1950 to 2010. I think the main reasons are increased awareness and better access to specialized centers. Because there are no biological markers to screen or to diagnose cluster headache, several groups have tried to develop screening tools for cluster headache, and I found at least 7. And these are mainly questionnaires with questions that could differentiate between cluster headache and other primary headaches. And we tried to do the same when I was in Hull to develop a screening tool with images depicting different pain severities. And we tested on patients with cluster headache and migraine, migraine being the most common misdiagnosis. And I will only mention briefly, I presented this at a few headache forums. So these are the images that we included with different pain severities, some questions about intensity, the nature of pain, description of pain, feeling of restlessness, intensity of pain, cranial autonomic symptoms, location of pain, duration of pain. And we had help from 10 UK headache experts, members of BOSH, to design the question in this tool. I'll present the results briefly. Patients could score a maximum of 32 points, and there was a significant difference, significant statistical difference between the scores in the migraine group and the scores in the cluster headache group. And then we did a ROC analysis to see if we could find a test item that could differentiate between cluster headache and migraine. And actually, the best test is the total score of the tool. 25 out of 32 seems to be the best score with a good sensitivity and specificity. However, we couldn't find the single test item that could reliably differentiate between cluster headache and migraine. So it's not the restlessness or the cranial autonomic symptoms or the intensity of pain. It's usually a combination of question that can help in making a diagnosis. But I think everyone can argue that they have enough paperwork on their desks and they don't need another questionnaire or more paperwork. So I think ultimately what is going to improve the diagnosis of cluster headache is raising awareness. So if people haven't heard of cluster headache, they are now going to think of cluster headache. Second is medical education in medical school or during training. I think people should hear about cluster headache. And finally, I think addressing the stigma of headache. Primary headaches are very common, causing a lot of disability, and I think these patients deserve more attention. Thank you.
Oh, thank you very much, Alina. Sorry, I was writing a question while you were speaking, so very well on time. So we'll come back to the questions at the end of the 3 talks. I mean, I agree with you that cluster headache, when they go to their GP, and if they have had the diagnosis of cluster headache, the GPs often tell us, well, you go back to your headache specialist because I know nothing about it. And the diagnosis in primary care, unless the GPs have got interest in cluster headache, it's very difficult to make a diagnosis. I mean, I've never seen a GP making a diagnosis apart from people like David Watson and David Koenig. So let's see what tips David Watson is going to tell us about, that if you are a GP in primary care, how you deal with or make your colleagues aware of this condition to make a diagnosis. So David is a general practitioner with the interest in headache disorder. He was a member of the BASH Council. He's working in a GP practice. You can see that now, Hamilton Medical Group. And he is also working in Aberdeen. And he's going to tell something very interesting about Aberdeen and Hull fairly soon. Come on, David, that's your turn.
Fires, thank you very much. Can you hear me okay?
Very good,
good. Yeah, and thank you for Peter and Alina for their talks. I might pinch some of Alina's slides if she's agreeable. They were excellent. I said I'm a GP in Aberdeen 4 days a week. A day a week I work at the Department of Neurology. I've been doing the headache clinic there for about 15 years. I just mentioned to Fires there was an article I saw yesterday for encouraging staycations here in the UK because of COVID, and it was the top 10 small cities in the UK to visit, and Aberdeen and Hull were 2 of the top 10 small cities. So that was nice to see. So just my disclosures, I've had some honorariums, conference sponsorship, consultancy fees from some of the migraine companies and a non-migraine company in the last 3 years. So I thought what I'd like to do just in the few minutes I've got, just look a little bit about the background to primary care. I'm conscious that we do have some international delegates as well, so I won't go too much in UK specific. I think it's probably generalized across the world, but GP training and workload, a little bit about diagnosis, and then about referral and management of cluster headache. So certainly on a UK basis, an average GP will probably see about 5 or 6 headache patients a week, about 3% of all consultations. 94% of all episodic disabling headache presenting to a GP is a migraine. That's from Stu Tepper's landmark study, which I think is one of the kind of seminal studies from a primary care point of view when I speak to GPs, that if someone's got an episodic disabling headache, 94% of it is migraine. So if a GP's only got roughly 1 or 2 cluster patients on the register on the list, and that comes back from Alina's epidemiology, 1 in 7 people having migraine, 1 in 1,000 having clusters. So we've got roughly 100 patients for 1 cluster patient. So GP's not going to see cluster patients that much. And if we look back to medical student teaching, this is information I've got from colleagues. 75% of medical students get probably no formal headache training, and most is on secondary headache. And likewise, most GPs get no formal headache training as postgraduates. If we look at what's happening in primary care at the moment, I'm sure this is in the hospital as well, but primary care consultations between 2018 and 2019 in England went up by 1.2%, but there was a 1% fall in full-time equivalent GPs. In other words, more work to be done by less doctors. And that's again alludes back to the data Alina gave about GPs looking at shorter consultations and maybe less likely to make the diagnosis. And the reality is that actually there's a multitude of good guidelines out there. We've now got in the UK the BASH National Headache Management System, and there's absolute excellent guidance there on managing and diagnosing cluster headache. But GPs actually are bombarded with thousands and thousands of guidelines. I looked at my local intranet today, and we had about 2,000 documents which are various guidelines, and the COVID ones that we've been getting every week, apparently there's 600 new COVID guidelines we've been given, and there's so many that people who do the internet just don't have time to even put them on the system. The other thing that's relevant to headache is that in the UK, Scotland's just diverged from England a little bit, but there was a thing called QOF. This was performance-related pay for doctors, and headache was never part of the QOF payments, whereas GPs were given targets for diabetics on their sugar levels and cholesterol, hypertensive with blood pressure, etc. And what was designed in QOF was things that were quite easy to measure. And because of that, in headache and headache management, it's not easy to measure. It was never became a target. So what's happened in primary care is, because there's a performance-related pay, GP practices have had a doctor skill up in diabetes, a doctor skill up in hypertension, a doctor skilling up in airway disease, but there was no incentive to skill up a doctor on headache. So it's still really very much a Cinderella management in UK primary care, but we see lots of headache patients. So what about the challenges of diagnosis? So we've certainly got this whole thing about diagnostic. Oh, sorry, I've gone too ahead. We've got thinking about thinking errors that we make when we make diagnosis, and what kind of heuristics that we get bogged down on. So you're anchoring on a first diagnosis, first impressions on selected symptoms or signs. So example, although most GPs and doctors haven't had formal headache education, they do remember from some lecture they had in second year at medical school that patients with cluster headache get cranial autonomic symptoms. So they get a patient coming in with cranial autonomic symptoms, automatically saying, well, that must be cluster. And as Alina rightly pointed out, the most common misdiagnosis of clusters is migraine. And we know that, as the prof mentioned there, about having cranial autonomic symptoms in migraine, and they're not so specific, they're not so often, and they're not strictly unilateral like cluster. And then again, anchoring on someone coming in with migraine symptoms, noise and light sensitivity, nausea. So GP thinks, oh, well, that must be migraine, but not really understanding that cluster patients also can get noise and light sensitivity. And one of the things about a headache history, as we all know, you have to be quite forensic in the history. So the prof was mentioning about the symptoms being unilateral in cluster, so unilateral light sensitivity, unilateral noise sensitivity. So if someone has noise and light sensitivity, you actually have to pull it apart a bit more. Patients with cluster can get aura symptoms, but again, as most GPs, aura must equal migraine. And then other thinking errors that if you've got a cranial autonomic symptom such as a blocked nose and you've got frontal headache, then it must be a sinus problem. And we've all seen patients who've had nasal steroids and sometimes getting nasal surgery. And again, that was one of the common misdiagnoses that Alina did. And I think also not being aware of the high value questions and getting a diagnosis. So when I have a student to the headache clinic, I ask them to think of what's your high value question, and they'll say, oh, site of headache or duration of headache, whatever. But my high value one is, what would you do when you get the headache? And I think Alina's video that she showed from YouTube was very much highlights this idea that most cluster patients have this restlessness and they want to move. And what's really interesting, if you look at migraine patients, that if migraine patients are a bit restless, they still want to try and keep their head still. So asking them about what they would want to do with their head. And I think the other key point we need to always think about is untreated headache duration, and both speakers have mentioned that already. So we see patients who get referred up as having cluster headache because they've got short duration headache. Dear doctor, I saw someone last week, dear doctor, please see this patient with cluster headache. I think they need an MRI scan. They have short duration headache. They're getting 3 headaches a day, and they've got cranial autonomic symptoms. And you ask the patient about the headache. Well, what would you feel you want to do when you get the headache? Oh, prefer a bit quiet, prefer to be a bit still, maybe go and lie down. Oh, how long does your headache last? Oh, about 3 hours. That's a bit confusing. And I say, well, what if you didn't take any painkillers? How long would the headache last? Oh, it'd be all day, doctor. So sometimes my GP colleagues forget that we're looking at untreated headache duration, and that's the important thing here. What about challenges with management of cluster headache in primary care? And what about referral? And I think I'm going to throw some questions out here that maybe I get Peter and Alina to pick up a little bit later. So should patients be managed in primary care? Should we be referring all patients with cluster headache? So if I've got someone who's had cluster headache for 10 years, they respond quite well, they get 1 or 2 clusters over a 24-hour period, it usually lasts 3 weeks, and their sumatriptan injection puts it away in 20 minutes. Should I be referring that person up to secondary care? Should all cluster patients be under the care of a neurologist, for example? What if a GP diagnosis is wrong? Alina got this spot on. So if you think you're focusing on the blocked nose and the frontal headache and someone gets referred up to the wrong specialty, that's going to delay treatments. GPs who are not confident in starting treatment, if we've got colleagues who, as I said, maybe only see 1 cluster patient a year, maybe at most 2 a year, it's not a bread and butter management. So if someone's not confident in starting therapy for cluster headache, there's a perception that sumatriptan injections are really powerful drug and it can only be prescribed by a specialist, would a GP then think, I'm not really confident in starting acute treatment, so I'll refer them, but actually by the time the patient's been seen at their headache clinic appointment, their cluster episode might be over and they've not had treatment for that episode. I know some of my colleagues in London, I know Giorgio Lambo has an urgent clinic and he'll see most cluster patients within 7 days, or the nurse can see the headache nurse. But you might have that delayed treatment because the GP is hesitant to start treatment. And again, if you've got a patient who's maybe having quite a lot of cluster headache, and again, Alina made a really good point in her research that patients just normalize, well, that's my headache, that's what I get. So maybe they're only allowed their 2 injections of sumatriptan in the 24 hours, could they be missing out on things that we can do, like gum blocks, like vagal nerve stimulators that might help? Should these patients get a scan? I'd be really interested in Alina and Prof's thoughts on scanning new cluster patients. What, the study Alina picked up showing that there's quite a lot of pituitary tumors, for example. And then, unfortunately, sometimes patients do get referred up by the GP and the doctor in secondary care gets the diagnosis right, but not the treatment. So this was from a neurology, it wasn't a colleague in Aberdeen. This was from somewhere, I won't say where it was. I saw this gentleman with cluster headache. Given that he's got repeated debilitating headache over the last week, I've commenced him on some nortriptyline 10 milligrams, which could be titrated up over the next couple of weeks if he continues to have symptoms. So the right diagnosis, but the wrong treatment. And then we've got challenges with medication. So if you've got someone who gets their episodic cluster starting, say, at the clock change in spring or autumn, really they need to have their treatment ready to go day one, so that they can immediately get on their sumatriptan, if it's oxygen or whatever their treatment is, or if it's preventive treatment for verapamil. But if we as GPs are struggling to see patients at the moment, should this be classed as emergency? Should that patient's notes be flagged and they get seen on the day to start treatment then? Or do they get a receptionist to say, well, this is not urgent because it's not been flagged up as an urgent patient, and they have to wait 3, 4, 5 weeks to get an appointment? I think certainly at the moment, primary care is the busiest it's ever been. I think any GP colleague I speak to in the UK is, I've been a GP now 31 years. This is the busiest I've ever been in my whole life. And managing things remotely in this blended work with face-to-face for some patients has been really hard. And there's been a lot of increased demand, certainly in the last 2-3 months. So I think our routine appointments at the surgeon at the moment are 4 weeks. So if this patient isn't flagged up in the system, they might not start the treatment immediately. There's the issue about oxygen prescribing. So in Scotland, oxygen can only be prescribed by headache doctors, headache neurologists. Obviously in England, GPs can prescribe oxygen, but some doctors have concerns about patients who smoke. And I'd be interested on the Prof's comments on that. I remember actually I asked him a question about oxygen smokers, and he quite rightly turned to me, can you quote me a paper in which anyone with cluster has blown their house up? And I think the answer is no, but some GPs worry about that. But they might prescribe oxygen, but do they actually give the right breathing system? Is a high flow, non-rebreather mask, a demand valve? Because we know low flow oxygen is not going to really work. I think the headache community has done a fantastic job over the last 10 years raising awareness of medication overuse in patients with migraine. But some of my GP colleagues don't realize that unless the cluster patient also has migraine or migraine genetics from the family, you will not get medication overuse headache for using a triptan once or twice a day for your cluster. But I still see patients who come to the headache clinic saying, I'm only getting 4 prescriptions of my sumatriptan injection a month, and yet they're getting 2 clusters in a 24-hour. So whilst we've done really well at educating GPs about medication overuse, they maybe sometimes confused that this is not cluster. We also have this perception still that sumatriptan is this really powerful drug with lots of horrible side effects. And we still see patients who are prescribed, a low dose, long-acting triptan for the migraine, not realizing actually the gold standard is sumatriptan injection. I know things like zomotriptan nasal can be helpful for some patients. It's a little bit of that's nasally absorbed, but sumatriptan is the gold standard. And then the other big dilemma for GPs and the comfort levels is about verapamil. So if we know that verapamil is the gold standard preventive treatment in cluster, if someone's going to have a prolonged episode, you'd want to get them started on verapamil straight away. But with all the issues about super high doses we use in heart block, we have to start low dose and build the dose up every 10 days with ECG monitoring, etc. But lots of GPs aren't comfortable about using verapamil high dose, are not comfortable about ECG monitoring, maybe feel they don't have the skills to interpret the ECGs. Still a few practices in the UK don't actually have access to ECG. They refer all their ECGs to secondary care. So there's barriers in patients going on to gold standard preventive treatment. So that's my run through. Very happy to join the rest of the panel for questions. That's Aberdeen Harbour on a sunny day. So thank you very much, Faiz.
Oh, thanks very much, David. That was really good. I think some of the issues that you have put on the slide is something that a lot of people have asked me here in Hull, the primary care sector. Well, I've got quite a few questions that people have asked me on the WhatsApp. I don't know why they have not used the question, the Q&A. Sunlight or temperature. Peter, which one is responsible for bringing them in autumn and spring? Is it the sunlight hours or the temperature changes?
Yeah, that's a good question. I'm not sure that's entirely clear. I think it's probably sunlight. That's an opinion based on two things: the susceptibility of attack frequency to circadian variation, which is clear, which is not so much a temperature thing. Low temperatures change during the day, and the variation of the prominence of attacks in places where it's not ridiculously hot. So north hemisphere, say latitudes up above 50. That I think it's probably to do with light rather than temperature. I don't think that's a resolved question, but
yeah,
we have some ideas about how to resolve it.
The reason I asked the question is because when I was visiting Pakistan, I asked their headache specialist and they said, yeah, it is quite common in spring and autumn. Now there, the temperature the sunshine doesn't change that much. It's only about an hour here and there. But the temperature significantly changes between summer and winter. So that's why.
What's the latitude of where were you in
Islamabad?
They said Islamabad.
So that's the northern area. And the temperature drops quite massively from 42 down to sometimes about 2 or 3 degrees. But the sunlight hours don't change that much. I think it's only a difference of about 1.5 to 2 hours.
Yeah, it's only 33, 34 degrees north, isn't it? So it's you kind of get this idea that it's tropical, but it's not really. That's 33 degrees away from the equator. It's not tropical, or 34 degrees, because you're more north, more or less, than most of India, more north than Saudi Arabia, and at the top, really sort of mid-Mediterranean. It's just one's concept of where, because Islamabad is not exactly sitting. It's not sitting on the equator. Let's put it that way. I take your point with, but there is time variability in Islamabad. If you compare it to the gold standard, which is the equator, isn't it? I'm guessing that for 33 degrees there must be between summer and winter there must be 4-hour difference in length or something like that.
I think it changes by about 2.5 hours maximum.
2.5.
If you actually look at the UK, you have a 17 hours day versus a 7.5 hour day. That's massive.
Yes, no, I agree with you. Well, it's even more massive if you start going to Norway and places like that. And I've often wondered whether one of the reasons that the Scandinavian colleagues, of course, are very clinically astute, but another thing to say is that there may simply be that there's more cluster headache the more north you go, and so they've seen more of it. So it's an open question. Pakistan's not so tropical as people would conceptualize it, is it? 33 is not exactly burning.
Depends which part of Pakistan you're in. If you're in Karachi, it's as hot as hell.
Yes. Yeah. Okay.
But Islamabad, can get hot and cold, but you don't get much colder in Karachi in the south.
Where's Karachi? Karachi's 25 degrees north. Interesting.
Alina, you mentioned investigating the cluster headache with the CT angiogram, I just couldn't understand. I mean, I can understand that the first ever cluster you do an MRI scan, but what's the logic of doing a CT angiogram?
So let's say if they come with a headache and the ptosis and hypomyosis by mimicking a Horner, I think I would do a CT angio because of that reason.
Is that you're worried about dissection?
Yeah, exactly. Yeah.
Right. You're not suggesting that every cluster headache should be investigated with a CT angiogram.
No, not necessarily. No, but I think sometimes the clinical presentation kind of could look like cluster headache, but could be an underlying dissection, for example. So yeah, sometimes I do a CT angio.
And the other thing I noted when you did the ROC analysis, did you do the ROC analysis on the restlessness? Because I couldn't see that you had that parameter measured there.
So the ROC analysis was done for the parameters with multiple answers, for example, intensity, mild, moderate, or severe. But for the items with the binary responses like restlessness, yes or no, was a different analysis done, and it was sensitivity and specificity, but was kind of differently done, just because of the nature of the questions in the questionnaire. But I haven't mentioned those because it was kind of too much to kind of cover everything. So I've just covered briefly a few things.
You see, the case you mentioned with the pituitary in your presentation, that person has had episodic cluster headache for years. And this is the reason that nobody scanned him. I've not, that's the case from Hull. And suddenly he started to lose vision, and you did a scan and found out that he's got a huge pituitary tumor. Very strange. Peter, have you ever come across something like that? With episodic cluster headache for 10, 12 years, every year, every other year, and suddenly the cluster comes and they lose vision, and you scan them and you find a huge pituitary tumor.
Well, personally, I haven't haven't seen that happen. The previous editor of but 3 of the journal Headache, American neurologist from the Mayo, reported a very similar thing, case of episodic cluster headache, that when they eventually imaged him, had a big pituitary. I think it's complex, this imaging side of things. I guess that one thing to say is that cluster headache's more or less a lifetime event. Your bouts, interbout intervals might get very long, and you might die of something else. But if a patient's going to have this for a very long time, so there's something to be said for digging around at the start to understand whether you need to worry later on, because it's such a. If you think about, you do a scan and it's got a useful investment of at least of 15, 20 years. That's not a bad spend. On the other side of things, the utility of scanning episodic cluster patients that are typical is pretty small. The return on that is going to be pretty small. You've got to ask the question. It's a resource allocation question, isn't it? I mean,
but I think that
if it was just taking a blood test and it costs next to nothing, we wouldn't have this discussion. But because there's a resource implication to it, it's a little bit trickier. So I think it a little bit depends on what the access is to resources. Yeah. At the end of the day, it seems to me like you shouldn't see it as a scan in a year. One should see it as an investment over a longer period of time, which is useful for everyone involved. But I wouldn't criticize people who don't do it for episodics. For chronic is different. I mean, it's a horrible problem. You're looking for any way you can find to change the direction of traffic for a chronic cluster headache patient. So I think it's hard to not investigate them at the get-go. For episodic, it's more. Yeah. I can see both sides of the argument.
Yeah, because I think for a little while it changed my practice, because if I have missed a huge pituitary tumor in an episodic cluster headache, I would start scanning every cluster headache. Yeah.
Well, this is a great problem in medicine, isn't it? We tend to be bitten by the last bee that in our bonnet. So that's the person. It took me years to get over the first person I saw with aseptic necrosis of the hip with cluster who had steroids, several bouts of steroids in a year. I'm not sure my brain has ever gotten over seeing the result of that. It's kind of the nature of the way we practice. You retain the awful things because they just sort of stand out, and it's hard to rationalize. It's hard, I consider myself rational, but it's sometimes hard to get that out of your head.
Absolutely. I mean, I had somebody with steroid who had a perforated peptic ulcer because of this steroid.
And it makes you nervous next time.
Absolutely. David, the two things in my experience that usually we miss the diagnosis. One is that even people with episodic cluster headache, they never see the same GP again, because by the time they see a GP and tried a few medications, the episode is gone. The next year when he comes, he sees a different GP. And the next year when he comes, he sees a different GP. And that's how the diagnosis gets missed. Is it something in the primary care that you now have that flags up that the same person has repetitively presented with headache?
It's a really good question, Faizan. I think Alina alluded to that as one of the patient factors as well as GP factors, that your patients, by the time they've sort of seen one or two different doctors, the 4-6 weeks episode is over, it goes to the back of their mind, and then the following year they come back and they're back at the square one again. I think just as a doctor, I would always say that if you've got someone presenting with the same thing 3 times, or you've tried 2 or 3 different treatments, you need to go back to the beginning and reevaluate your diagnosis. And that's not just with cluster headache. We'll do that all the time. I think probably one of the good things with COVID is we talk with colleagues in primary care a bit more, because we all probably have more meetings, which inevitably become, as well as management things, become clinical. But I think that's where hopefully it's really difficult to give you a straight answer, but I'm quite a pedantic individual. So if I, for example, at the moment doing a lot of telephone stuff, I will go through the notes before I phone someone, and we use Vision as our clinical system. It's got like a Google box on it, so top left corner, so I can type in headache. So that if receptionists have said to me, the patient wants you to phone back about headache, I'll type headache into my little Google box, and that will list every consultation where someone's written headache in it. So I can then go back and say, well, look, they had this, this, and this. So, and I said, it might just be headache, could be other conditions as well. So hopefully there's a means of then going back and looking at what colleagues have done. And I think sometimes it's back to these thinking errors that you've got to, I mean, I'm now at the age where I question every diagnosis made by any other doctor that, and I'm including primary care and secondary care when I see a patient, because I know that probably at least 1 in 10 diagnoses will be wrong. So I think it's back to having enough time to have a little bit of a note review before you see a patient, and thinking in your own mind, what has someone done previously? Is that correct? But I think that's an individual doctor thing. And if you're in a failing practice where there's 6 doctors have become 2 doctors and 4 nurse practitioners, and there's 60 people in the waiting room, then people maybe won't be as pedantic as me and spend time to go back. So it's a very long answer to your question, Faiz. I'm sorry, but I think it's about going
discussion basically.
Yeah.
When I tell my wife, because she's a GP,
yeah,
you have to take a good history, and she laughs at me and says, in 5 minutes. Mm-hmm. And I said, yeah, well, 5 minutes is quite a long time. And she said, yeah, but you only see headache. We see thousands of other conditions in the primary care.
Yeah, I mean, that's the difficult thing as well. It's very prominent at the moment, because there's this perception that GPs are sitting all day drinking coffee and not doing any work. So when they've got hold of you, they say, oh, but whilst they've got you, and there's 6 other things come out. And that's one of the joys of doing my headache clinic. I say, well, actually, I'm here for the headache, and please leave the other stuff behind. So your wife's right, Faiz, but I think it's back to what I was saying, and that's what Alina's alluded to, is what's the high value question. So the high value question is, how long is your untreated headache, and what would you want to do when you get your headache? So, you know, yes, it's nice to have, if they've got some migraine symptoms or they've got cranial autonomic symptoms or whatever, but the high value questions. So I think the more experience you get in asking headache histories, you can then take out those high value questions. Alina, would you agree your high value questions from the work that you've done is about what would you do when you get a headache, about the restlessness? I think your idea of showing the video is fantastic. And then it's untreated duration, short headache. Would you have any other high value questions you would suggest, Alina?
I think the limitation of the questionnaire were the fact that we asked the patients, do you feel restless during the attacks? And they were asking with yes and no. And actually that question, the specificity of that question was low, was about 40%. So I think it's also important how that question is phrased. Probably a better question would be, do you have a restlessness behavior? What do you do during an attack?
Yeah.
Rather than answering with yes and no.
Yeah.
So I think that was the limitation of the question, and that question specifically wasn't specific for cluster headache, and a lot of patients with migraine responded yes to that one.
I would agree with you. I mean, I normally say, what would you want to do when you get the headache? Do you want to go out and bang your head against the wall, go outside, walk the dog in the dark? Do you sit there and do you rock up and down, or do you prefer just to keep still? And that, I think that's something Peter taught me once with migraine patients. Might be restless, but they like to keep their head still. It's quite specific. I can't remember when you mentioned that once, Peter, but it's a very just useful thing to store away when you're doing a headache history.
Yeah.
Yeah, I mean,
it is extraordinary. I mean, nothing's 100%, but these are 90% questions, more or less.
Yeah.
Yeah. I mean, we when Alina and I were doing these questionnaires, we thought, we put the question as, is your pain severe or excruciating? And we thought the answer would come excruciating for cluster and severe for migraine. And we were surprised that most of the chronic migraineurs said it's excruciating. Is that right, Alina?
Yeah, that's true. I think one of the questions suggested by the experts of Bosch, because we had some help from 10 people, one of the question was, is your pain like excruciating agony, or your attacks like excruciating agony? So we really thought that is going to be a good question to for cluster headache, but actually it wasn't. A lot of patients with migraine responded yes. So there was an option to say yes or no. So a lot of patients with migraine said yes. So I think that's the limitation of the questionnaires compared to an interview, because you are kind of suggesting the questions to the patient. Do you have excruciating pain? They'll probably say yes, rather than asking them, please describe your attacks or what happens during the attacks. So probably an interview with a group of migraine patients and comparing to interviews with cluster headache patients, probably that would be more useful.
And we thought that because they have never had a cluster, for them, that was excruciating pain. For people who have had cluster and migraine, they would probably give up the answer that we actually expected, wasn't it? Peter,
Yeah, it goes to show you asking people about their pain is important, and making a note of it important. But it's such an internally referenced experience. You know, if you say what's the worst pain you've had, then you have to think about. Then people will have different personal experiences. I remember when I was much younger, having some dental work done without an anaesthetic. That was very painful, I have to say. I probably having the drill, you know, actually go through your tooth and hit a nerve. That's very painful. I would rate that there, but I haven't had a cluster attack, so I don't know if it would be worse. It's all a question of, you know, what's your frame of reference, and also a little bit, you know, well, what do you think? What else is going on at the time? Somehow, if you're doing some sort of DIY junk and you bang your finger with a hammer, it seems worse than it actually is. If you don't like doing DIY, I don't want to trivialize people's pain, but I do think it is circumstantial.
The thing is, for women, we can ask the worse than the childbirth, but in men, there is nothing we can compare it with. Okay, Peter, I have one question.
Well, I mean, there's always having one's testicles kicked or something like that in a rugby or some sort of interactive game. I think men use kick being injuring the testicle as a sort of shared unpleasant experience.
Peter, the question I was going to ask is, we see autonomic features on both sides in quite a lot of people with cluster, but 99.99% we see the pain on one side. What's the pathophysiological explanation for that?
Well, I think that it's more common to see lateralized autonomic features in cluster patients than bilateral autonomic features. As if you want to put a blanket rule, if you then ask the question, do you ever see them bilateral? Sure, but in migraine you see them unilateral. So the simple answer is the projections are bilateral. If you look at the projections of the trigeminal system into the brainstem, there's predominantly a unilateral projection. But there is some projection there's some bilateral projection. And it's the same thing if you're driving this cranial autonomic pathway, say from the brainstem, and I mean above the superior salivatory nucleus. Most of these outflow pathways go through will activate both the homolateral and the contralateral superior salivatory nucleus. They just tend to be 80% of it will be going down one road and the other 20% going down the other road. So I think most things, most of these pathways have predominant lateralization and some degree of bilateral activation, which is why the terrible thing about that is what I just said means that almost everything is on the cards. And what we're talking about when we talk about lateralization or any of these things is what is the middle person who's obvious, who's almost made the diagnosis themselves on Google. I don't know what your experience is, but at least half the patients I see with a TAC have worked it out for themselves before they get there. They've Googled around, they've looked on the web, they've talked to people, and by the time you speak to them, they've actually got a pretty good idea of what they've got and some idea of how they'd like to be treated. Thought about it quite a lot. So where it's typical, it's typical. When it's not typical, I think it's not surprising because the pathways do have some bilateral projections.
Well, that was going to be my next question to Alina. You mentioned that we have reduced the time to diagnosis from 18 years or 19 years down to 2.6 years. Is that Dr. Google that has improved it, or have the healthcare professionals done something?
Well, I think it's also work from people in the headache work, increasing awareness, especially in the UK, there are a lot of meetings, a lot of webinars. And also the access to headache clinics it's very good in some countries. And I think the results that I've showed where things have improved are countries that are doing a lot of research in headache. There are a lot of headache specialists. So I think that's the reason as well. It's probably the work of the people in headache trying to raise awareness. And it's probably the internet as well. Maybe people go on the internet and they self-diagnose. In that one of the systematic reviews that I showed, although I haven't mentioned, some of the patients actually self-diagnosed and they go to their doctor with, look, I've Googled this and I think I've got cluster headache. So I think that plays a role as well.
I think there is a combination of quite a few other things as well. So the credit doesn't go entirely to the doctors. Now, David, the point that you made in your presentation was, would cluster headache be managed in primary or secondary care? Now, I would open that question to the other two panelists. In my opinion, unless you are a GP with special interest in headache, I think cluster headache should be diagnosed, managed, treatment-wise, everything in secondary care. There is a problem with verapamil ECGs. There is a problem with lithium levels. There is a problem with monitoring it. Particularly if you're using the gamma code in this COVID situation where you don't want to get them in the hospital. I think this is a secondary care territory, but I'll be very interested by views of Peter or Alina.
Alina?
I partially agree with Fayaz. For example, if patients with cluster headache have episodic cluster headache, and let's say they go on remission for a few years, they can be in touch with the headache nurse. So when they get their second attack or an attack, they can get in touch with the headache nurse and be brought to clinic straight away, rather than keeping them on a routine follow-up. So I think the plan would be to be discharged back to GP, but with a link to the headache clinic rather than being routinely followed up in clinic. But it's a different story with the chronic cluster patients. I think those should be managed in a headache service, in my opinion, just because of the reasons that you mentioned, Fayaz, already, with the verapamil and the lithium.
David?
Yeah, I think that's one of my thoughts. I think chronic's a separate condition, but with episodic, if someone gets their first assessment at the headache clinic, they've had their scan, they've got their plan of action, and it works well for them, and they maybe get a cluster episode every 2, 3, 4 years, I would have thought a competent GP could then manage that plan, especially if it's like they get 3 or 4 weeks of 1 or 2 cluster a day, and they don't want to go on prophylaxis because it's not really going to be needed. They're not wanting intermediate treatment like steroids, and they're just happy because their sumatriptan will work quickly in 5 or 10 minutes. And I think the initial workup's already been done in the headache clinic, so we've excluded. There's a diagnosis made, secondary pathology has been excluded. There's been a very good management plan, but I think you'd always want to have the fallback position, as Alina said, so as if they then went into a cluster episode 3 years later and it didn't seem to be responding as you expected, you've got that immediate way back into the clinic. I think just in terms of different clinics will have different capacities to manage patient-centered care. A lot of headache clinics won't have nurses to help. A lot of clinics, maybe someone's just doing headache 1 or 2 days a week. So I think it will depend a bit on geographical location. If I suppose we're using telephone calls and near me better than we've had in terms of video consults. But if I've got someone who'd have to fly down from Orkney or Shetland to Aberdeen, then if the GP's got a good plan and the GP can manage it, then maybe we don't bring them back to clinic. So I think it's an individual assessment, but I was just throwing out there because I think you're absolutely right. Chronic is a separate condition and should be under the auspices of the headache clinic. But someone who gets episodic cluster now and then, I personally would be happy as long as there's a safety net for them to come back into the clinic if need be.
Yeah, and I think that's right. It's very regional, isn't it? I mean, we have one of my fellows is the cluster buster for the week. They'll see someone with comes back into bout that week, talk to them, and if we need to do something, we'll do something. We've been doing that for forever and a day. That's how I managed to train so many people in the area, because it's a service, and it's also an obvious opportunity for people to get more experience. I think in medicine in general, you should do what you're comfortable with. I wouldn't want to prescribe a statin. Might sound like a stupid thing to you, David, because you probably prescribe it every day. I'm happy to take my statin, but I don't know which one I'd start with, and it's probably an obvious answer for you. Now, if you show me someone with cluster, I know exactly what I'd do first. And yourself, and all the GPs with special interest that I interact with got it all sorted out, because it's an area of interest. And I also see letters like the text that have been shown, that where someone's got cluster and they get started on amitriptyline. Well, it's just not going to help anybody. It's all a question of how comfortable you are with the thing. I also take the view, if a colleague asks me to do something, to see somebody, I don't second guess whether they're silly or they shouldn't do that or whatever. I just take the view that that's my job. That's why you're called a consultant, because people consult you. It's what it says on the jar. And if you don't want to be what it says on the jar, get a new job. And don't complain about the fact. That people send you patients, because that's actually that's your job.
Exactly.
FYI.
Yeah.
and if you don't like a particular area, well, okay. You know, if you don't like headache, for example, maybe you should train a little bit in it, or talk to, you know, work out how you're going to do it. But and then try and write letters back that aren't smarmy, but that are useful. That you know, set out the thing and say, well, this is what we're going to do very clearly. I remember a long time ago, a colleague, someone was asking them how they investigated hereditary spinocerebellar degeneration presentations, and they said that they used to that they would get out the last letter that Anita Harding sent them, see what tests to do, and then order the test that Anita Harding had ordered the last person that they referred. And it was a slightly glib remark, but what it is, if you're referring to someone who's writing sensible things back, then you learn from that. And there's nothing, as you say, in your practice, there's nothing wrong with checking back on the last cluster person, and you sent them to the neurologist who said, well, we do this, and you give them sumatriptan injection, blah, blah, blah. It's a learning process. Everything is about how comfortable you are. So I think if a GP is uncomfortable with episodic cluster headache, very happy to see them. If they're comfortable and just want a roadmap, very happy to give you a roadmap. With chronic cluster headache, they're going to be around for a long time. I agree with all of you that that seems to be something that headache specialists ought to take on, because it's rare enough that the bandwidth is okay, and dreadful enough that that it's probably better in secondary care.
Yeah, I mean, I concur your view, Peter. I mean, when I was the clinical director for quite a while ago now, the manager used to tell me, get out all the inappropriate referral. And I said, to me, there is nothing inappropriate. You can ask for more information, but you can't reject as inappropriate. If I have got a little chest discomfort, and if I ask a cardiologist, even I'm a doctor, the cardiologist wouldn't say to me it's inappropriate. He'll ask me a few questions, and he will reassure me. So a GP is asking the question, and because we were getting so many referrals, so I think I like this idea. Tell the managers it's nothing inappropriate. If you feel uncomfortable, that's where you are for helping.
Yeah, part of the problem, I mean, if expecting GPs not to be able to ask, the GP who asks the question is the one that you want to have a relationship with. It's the ones that never ask.
Yeah.
And the person's, this poor cluster person's stuck doing amitriptyline for five years. Yeah. That's the one that bothers me more than the people who ask, because at least the people who ask, there's progress you've got to see it from the patient's perspective. So a lot more time for people who ask than people who just sail off into the deep blue sea.
I think that's really useful from both of you there, because at the end of the day, there's no such thing as an inappropriate referral, and it's just different people have different expertise in different areas. And I think if someone feels that for the patient's treatment, they're now out with their expertise. So for example, I'm quite good at prescribing the first 2 or 3 HRTs for ladies, but if they don't work, I need guidance on where do I go next. So I think it's really helpful to have those comments about that. And I think Peter's right. It's the I don't know doctor is the one we should be worrying about, and the ones who want to ask the questions. I think it's absolutely fantastic. And again, I like seeing these patients because we know we can do things to help them. So it's really nice when they come back and say, wow, doctor, that gum block you gave me stopped my headache, and that sumatriptan, wow, why have I not had that before? And it's so rewarding to help these people.
It has been the optic on headache has been that there wasn't anything you could do, but I think that's so much changed in the last 20 years. There's nothing more rewarding in practice, I don't think, than someone who comes back and sort of looks at you, gets a bit blurry-eyed and says, wow, that was really helpful. Yeah. I mean, I'm a sucker for that sort of thing. Or who wants to come back and, at least pre-COVID, and probably it's going to happen again, come back and hug you and say, well, thank you. That's great medicine. And that happens a lot in headache, a lot more than people appreciate it.
Yeah. I've pieced a migrainer on a Runab who was trying to give me virtual hugs down the phone yesterday because she said, I can now go to Tesco. I just couldn't even go into Tesco before. You're just changing their life. It's such rewarding stuff to do.
Yeah, totally.
Right, I've got 2-3 very quick questions, and then I think we're going to come to a close. One is for Alina. Aura happens in cluster, and autonomic features happen in migraine. What in your survey you've learned how to differentiate these two?
So aura can happen in both, and cranial autonomic symptoms can happen in both, actually.
Yeah.
I haven't looked at the aura in kind of the studies that I've done. I've only looked at the cranial autonomic symptoms. And it was just a question of yes or no. The patients had just to say if they had cranial autonomic symptoms, yes or no. But from that kind of study a decade ago, it kind of shows that there is a difference in the pattern that the cranial autonomics happen, and they're more kind of prominent and consistent in cluster headache rather than migraine. So I think that was a limitation of the questionnaire as well, just kind of asking the binary question, yes or no.
Because I know 14% clusters have aura and 30% of migraineurs have autonomic features. So based upon their presence, you cannot dismiss it. Oh, if it is aura, you dismiss cluster.
Oh yeah, definitely. No, yeah. Aura can happen in cluster headache as well. You shouldn't dismiss it. I think there are other key clinical features of cluster headache.
Okay, 2 questions to Peter, last one. Could I have some explanation from you why gamma core and CGRP all trials show good response in episodic but not in cluster headache, chronic cluster headache?
Well, they're different. Yeah, that's a good. It's a good question. I think that the distinction I was trying to make at the start was that episodic cluster headache, when it turns off, it turns off. There's something happening in the brain that turns off. So if you take an episodic cluster person in between bouts, you can't trigger them. No, it's just not a thing. But if you take a migraine patient who hasn't had an attack for 4 or 5 months, you can still trigger them, which is extraordinary when you think about it. Their biology continues to be active. I'm quite excited. I mean, I think it's a very exciting distinction. Why is it that, for example, the question is asking sensibly, why the stimulator and the CGRPs don't work in chronic cluster headache? I think it's the degree to which the attack is tractable. So in episodic cluster headache, clearly whatever the mechanisms are in the brain, they can still turn off. And I mean, the whole attack can turn off. And I think that, whereas in chronic, they don't turn off. I think that in episodic, the pathway is more susceptible to those therapeutic interventions, whether it's the input from the vagus or the trigeminal autonomic reflex. It's more, those pathways are more susceptible in some sort of way than in chronic cluster headache, where it's susceptible to turn off. Whereas in chronic cluster headache, we can't turn them off, and that's not so. It doesn't surprise me entirely if we can't turn the whole thing off, then it's very difficult for an acute therapy to stop the attacks. I think we'll find in chronic cluster headache, for example, that those ones that cycle into worse periods, it would surprise me a little bit if you couldn't turn those off, if you couldn't treat those with these sort of therapies, in contrast to trying to treat attacks in that interregnum phase where they've got attacks, but they're not quite as bad as they are when they're what I would call micro cycling. So I think it's a question of susceptibility to treatment.
And the second and the last question is, I haven't had any success with epilim and pizotifin, sodium valproate and pizotifin, but I see
in cluster.
In cluster, I have had no success ever. But I've seen some of your patients on sodium valproate and pizotifin. Have you had good experience with it?
No. No, I mean, as time goes on, you really start to see where the noise is in your life, therapeutically, and I'd be surprised if I can't remember the last time I started someone with cluster headache on pizotifin, or personally started them on certainly pizotifin, or personally started them on valproate. I've fallen out of love with with those drugs. I just don't really think they get anywhere.
I think
So no.
I think it may be as a last resort when you're really clutching the straw that you
Yeah, I agree with that, but that's exactly what you're doing. But I've kind of come to the position that it might be better just to tell people that that's a waste of time, rather than, it's hard. It's harder to say that's not useful than it is to just roll out something else and give them a 6-month appointment and hope for the best that they've sort of micro-cycled into a better place. So I'm out of love with both of those.
I think finally, I'm just going to answer the 2 questions asked on the quick Q&A. The patient that we described with a craniopharyngioma or a big pituitary gland didn't have visual field deficit until very late. And just looking for bitemporal hemianopia is not something that you can say with confidence that they wouldn't have a pituitary problem. Secondly, I think migraine patients can manage their condition relatively better than a cluster, because I think cluster, you do require people to help them. And the third thing was, is there any algorithm for making a diagnosis of cluster headache? Well, Alina and I have tried it for many, many years to come up with a very straightforward questionnaire, but we were unsuccessful. So unless somebody in future comes up with, we haven't got a straightforward algorithm. So gents, thank you very much, Peter, David, Alina, for your precious time. I think I enjoyed chatting with you. I have learned quite a few points that were sticking in my mind for a long time. So have a good evening, and hopefully we'll see you again in future webinars. Thank you very much.
Thanks for organising it.
Thank you very much. Thank you.
Thank you, Faraz. Thank you, everyone.